Hi, I'm Allison Muller, and today I want to go over steps that I take as a toxicology expert witness in evaluating medical malpractice cases. Now, this is certainly an oversimplified list, and every case is a little different, but these are just some general things that I do that many of which attorneys can do themselves even before they consult a scientific or a medical expert for their medical malpractice case. And also, these things apply to both plaintiff cases and defense cases, because really, as an expert witness, they are the same. We are just trying to explain the science, and the question that needs to be answered is the same question or questions that need to be answered by both sides. They're just hoping for different answers. So the first thing that I do when evaluating a medical malpractice case is to see what records I indeed have to begin with. And if all I have are records from, let's say, the hospitalization in question where an error may or may not have occurred and may or may not have caused harm to a patient, that's very helpful, but it's necessary many times for me to have more information than that, because I may need to get information about the patient's past medical history. And past medical history, you'll see the abbreviation PMH on medical records, is documented when a patient is admitted to a hospital or when a patient arrives for their outpatient provider visit. But it's not necessarily the same history every time. The patient's medical history is only as good as the patient reports oftentimes. So if I have past medical records, I can really piece together, well, what medications does the patient truly take on a regular basis? What other medical problems have they had? Have they had similar medical problems to what they were possibly experiencing from a drug in the past? For example, if somebody's reporting hair loss from a drug that they're taking, but meanwhile they were on Propecia 5 years ago, which is an oral drug for hair loss, well, that makes me think, well, they've had this problem in the past. We need to really see if the drug had anything to do with it, or this is just a resurgence of the past problem. So when I say other records other than past medical records, pharmacy records can be very telling. And I don't only say that because my original training is in pharmacy. Because it tells you the pattern of use, or at least the pattern of how the person is refilling their prescriptions. And they may go to multiple pharmacies, so that makes it tricky. So if someone is using their insurance to pay for all their drugs, well, then you can just get the records from the insurance company and you don't have to go hunting for multiple pharmacies. But if they're paying cash, that makes it more difficult. Now, if it's a controlled substance, it's helpful if we have state drug monitoring records. Sometimes those are available to us, sometimes they are not. The purpose of those is to avoid the issue of pharmacy shopping for those that are looking for controlled substances from multiple sources. So in other words, if somebody is using opioids and they're going to different pharmacies, the state monitoring program would pick that up regardless of how they are paying for those drugs. In the hope of being able to detect if somebody is overusing drugs, going to multiple pharmacies, going to multiple prescribers. Another area that I would look at when evaluating a medical malpractice case is specifically the drugs that the patient is taking, and if any of those drugs could interact with one another. Now, when I say medical malpractice cases, since I'm a toxicologist, I'm looking at it from the medication-related aspect of a medical malpractice case. This is not if, the surgery went awry, or, if the procedure was appropriate or not. Those are issues that were for other experts. But for my expertise, it would be related to the medication specifically. And when patients are on drugs that have a long list of interactions, as attorneys, you should give these some extra attention. Lithium and warfarin are two drugs, and I want to give you a long list, but lithium and warfarin are two drugs that have a pretty long list of drug interactions. Not only do they have a long list of drug interactions, but they have what we call a narrow therapeutic index, meaning you don't have much room to play with between a therapeutic level and a toxic level. And one can go into a toxic level fairly easily. There's not a wide index there. So when you see drugs like lithium or warfarin and you have a possible medical malpractice situation, you want to evaluate if there was any drugs that interacted with one another. Looking at the dose of the drugs that were given to a patient, prescribed to a patient, sometimes this is more complicated than just looking up the dose, for example, in a reliable drug information reference, and determining if that's the appropriate dose to the patient. Because it's not just every dose is the best dose for every patient, because sometimes doses have to be adjusted based on things like age, other drugs that are being taken, medical conditions, kidney function, liver function. So there's all these different examples, even genetic factors. We're learning more and more in terms of pharmacogenomics and genetic factors that can influence what dose of a drug is optimum for a patient. So that's a little bit more complicated. But the dose really can be patient-specific depending on the drug. If you're reviewing medical records and you see that there's an antidote that was given, and I'll give you some examples of antidotes in a moment, get curious. Why was that antidote given? For example, if I see that naloxone was given to a patient, I want to be able to understand why from the records was naloxone given. It's not always spelled out for us coming into this after the fact. Was it because they thought that the patient came in with opioid toxicity, an opioid overdose? Was it because there was an interaction that maybe made the person more susceptible to opioid toxicity? Or was there an error with either the dosing of an opioid that was being given in the hospital, or how long they had the person on the opioid? Why was that given? Or an antidote like flumazenil, which is to reverse the toxicity in certain situations from the class of drugs benzodiazepines, so things like Valium or Ativan or Klonopin. Those are some brand names of benzodiazepines. Then it gets trickier because there's some drugs that are used as antidotes, but they're also used for other reasons too, such as glucagon. Glucagon is not necessarily always used as an antidote, let's say for beta blocker toxicity, but it also may be used for medical conditions as well. So when evaluating a medical malpractice case, I look for the presence of antidotes in the chart, and I want to be able to get a clear understanding of why those were used. When you see drug levels in a medical chart, we want to know why the levels were done. Was it simply for monitoring for drugs of abuse? Was it because it was a drug that needed to be kept in a therapeutic range? Was it because there was the risk of toxicity, or the question as to was the patient having toxicity? So levels like lithium levels, digoxin levels, acetaminophen levels, why are those being done? Again, that's a more complicated issue, so something that an attorney could recognize, but certainly take it a step further with a toxicologist as to deciphering those levels. So those are some things that I would want attorneys to think about when evaluating a medical malpractice case that's related to medications. And they can do that even before consulting a toxicology expert witness. Thank you for watching today's video, and I hope that you will join me for future topics in toxicology.